we have the next speaker, Dr. UNNIKRISHNAN NAIR. He's the medical director and managing partner for Chaitanya Group of Eye Hospitals. He's an excellent clinician and academician. So he will be speaking to us about the predicting surgical recovery and visual outcomes after macular hole surgery. Unni, to you.
Thank you, George. And we started with the ERMs, and then we're coming to macular holes. So macular hole surgery is rewarding, but often you're dealing with good vision, so you need a tight control of what comes out of your mouth, what you tell your patient, and therein lies the necessity of giving good, worthy promises to the patient. And the decisions are basically based on the knowledge you have. Imaging biomarkers have come to the fore in that. So this is a classic, I'm not going to touch it at all. So basically the first question, do macular holes close by themselves? So that is the first point. Stage 1 holes, you have up to 50% of stage holes can spontaneously close. So what that means is that when you see a macular hole, there is an importance in knowing the staging and the closure rates. Well, as this stage progresses, the possibility of closure and your intervention becomes higher. So how can you predict the closure? This is simple. Smaller holes close faster, larger holes the closure rate comes down. So I'm just going to skip these 2 slides. And so next, okay. This is just what there's no biomarkers here. You're just 2 pictures here. Without even looking at anything, you get the feeling that the hole on the top is not going to close and the hole on the bottom is going to close. So this is intuitive for you. Okay, so this is barring anything else, you have some intuitive knowledge here. Rectilinear square holes with no SRF, the chances of closure is less. This is something that goes into your brain. Ones with acute angles with cystoid macular edema, a bit of SRF, the higher the hole, the chance of closure is more. So based on these observations, all the studies, the parameters, the macular, the things come out. Again, when you see the hole on the top, you see a bit of operculum still attached, just as if it's just come off, you know this is going to close. The chances of closure are more. This is based on the surgeon's gut instinct. We have not reached biomarkers yet. So we have, like Dr. Sunil said, the lesser the duration, the better the vision, the more chances of a hole closure and better post-operative vision. Add to that the stage of the hole and the size of the hole. These are the 4 simplest parameters we get from looking at an OCT image, talking to the patient for about 5 minutes. But for all practical purposes, the most important measurement is the minimal inlet diameter. That is the closest points between the edges of the hole. And based on that, holes are divided into 250 to 400 and less than 250, more than 400. It's funny because we see all these measurements, and when we start measuring, we see only things greater than 1,000 and 700 and 1,000 and all those things. I don't know where this 400, I haven't seen a 400 micron hole for a very long time. They don't come to my clinic, okay. So there are loads of studies validating this particular point. Minimum inlet diameter, the most important measurement. One measurement, find the closest. Now I'll tell you there's a small fallacy in this later. Then you have there's another study saying minimum inlet diameter. And we have a host of indices. These host of indices, it's addictive. When you see a macular hole, you look at what has not been measured, can I make an index out of it? And I have also done that. I'll show you what I've done. So these are the typical indices. You have, basically what it does is incorporated the height of the hole to the base of the hole. And because you think of something collapsing and falling, the bridge closing, and you're imagining that the higher the hole, the more likely the sliding and the touching comes. That's what you're imagining. And all these indices. So you have one study that says one indice is good. The next study said this is better. The next one says this is better than both of them. The third one is an addition of the first, second, and third, and that's the best. So we practically do not use this much. So this is all the indices. We'll take a question who uses it. But this is interesting. ELM gap. That is, you're going beyond the hole closure. That is, you're checking how much the external limiting membrane, which is the most critical, that is the Muller cell representative, the most critical, whether that will close or not. So that is the minimal ELM gap. If the ELM gap is closer, the chances of the ELM gap closing and having a better post-operative result is higher. The whole inlet diameter may be smaller, but your ELM may start retracting way ahead of it. And in that case, you'll have a large defect in the end and the visual acuity will be poor. So this is an example of that. That's your ELM defect, and it's very close to the edge of the hole. And when it closes, your ELM starts reforming. You can see the ELM starts reforming very close to the edges in the beginning. This is a very close second or third post-operative week picture. So when the ELM gap in this set is slightly away, when the ELM gap is slightly closure, it is indicated that the hole didn't close and the ELM was very far away from the edges of the hole. So this is our fiddling with the ELM gap. We did something called the ELM angle. Trust me, it is just fiddling with the same thing. So we incorporated the height also into the ELM angle, and we took this particular angle between the height of the edge of the ELM and the space of the ELM, and we found that the more acute it is, the more chances of the ELM approximating. That is, we got a degree of 68 degrees. Anything less than 68 degrees in acute angle, the ELM approximated much better. So we just fiddling. We first saw something new, we went for it. That's it. This is something that is started off very promising. Preoperative choroidal hypertransmission. Whenever you see preoperative choroidal hypertransmission is less, it's good. It's more, it's bad. But when you look at it critically, if the hole is open, the choroidal transmission is more. So this indirectly was just another biomarker talking that if you had a larger hole, you had a larger transmissible choroid. So after this wonderful study, the last line was it may not be a good imaging biomarker. So this is something I'd like to, I'll just go to this, NFAS OCTA. So this is something that is really piqued my interest. The NFAS imaging of a macular hole. So we looked at two aspects. One was the octa, the FAZ size. Funnily, or not funnily, the FAZ became more normal after a macular hole surgery. Why was that? Because the cysts went away. So the distance between the vasculature shrunk, and it looked like a functional improvement, but it was actually a structural improvement that was happening. And the next thing we looked, this is our paper, we looked at the cysts. There were a couple of studies about the perifoveal cysts. This is a beautiful looking images I'll just show you. This is how the cysts around a macular hole look in ONFAS OCT. What we did is that we did manual segmentation, and we discovered there were two types of cysts. Basically, you had your inner nuclear cysts, which were larger and smaller area, and you had your outer plexiform or layer cysts, which were dot-like, smaller, but extended in larger area. Funnily, it was inversely proportional. The larger the hole, you had smaller area of cysts. The smaller the hole, you had larger area of percentage of cysts. So there were two theories. One is called the hydration theory. That is, the larger the cyst, more area, it gets hydration. We proposed a new theory called the RP contact theory. The cyst correlated well with the basal diameter. That is, when the RP was not touching the base of the hole, those areas had a lot of cystic areas. And this correlated with, phenomenally, the inner nuclear cystic area correlated with the post-operative visual acuity a lot. This is how we calculated, we binarized it, we divided it into outer layer, inner layer cysts. And this is another point I'd like to say. When we measure the minimum inlet diameter, you just measure across. But when you take an NFAS image of the minimum inlet, you find it's all different shapes. It may be just 300 or 400 in one diameter, but the other meridian, it could be 600 microns. So what happens is that all your indices are taken for a toss slightly. When you do an NFAS, it is not just the 180-degree linear thing you're measuring all around. It is not 400 or not 500 over there. This is another picture that actually shows the base shows the amount of ellipsoid zone loss also, the black area, which tells you there's a large area of ellipsoid. So NFAS imaging of macular holes, I think, is a really exciting way to go nowadays. So we just look at a few post-operative factors. We know what a flat open is. A type 2 is worse than a type 1. In the U, V, and W, we know the U closure is the best and all those things. So I'm just going to go quickly. The ellipsoid zone integrity, very important. There are many different ways of ellipsoid zone, and I'm saying that the best way to measure the ellipsoid zone is using NFAS OCT. So two other things is the Sanfil and the Donfil, swelling of the arcuate nerve layer, and the next is the dissociated. The dissociation has a temporary visual loss after macular hole surgery, and this is what it looks like. You can see a picture with all those small wrinklings on the top over there. And again, when you do an NFAS, you get this very nice picture of hexagonal patterns around it in the entire area where the ILM has been peeled. So this is an NFAS image of Donfil. So we try to compare Donfil, the appearance of Donfil with the direction of peeling, whether it's more nasal and temporal. The only thing we found, the downfall is greatest in the area where you initiate the pinch. The quadrant where you initiate the pinch, that's where we found the highest amount of downfall changes. So there are other things like having inner layer hyperreflectivity doesn't mean much, not much was found out of it, but this is important. ILM flaps. We use ILM flaps to show the patient after a week that we've closed your macular hole. There are two types. That's a stuffing technique and the cover technique. Basically, the cover technique is what is getting important now. Putting things inside the macular hole, it is not meant to be. So this is what you can see. There's a hole, it looks like an astronaut standing holding the two edges of the macular hole together. You can see that. So do not put unnecessary things inside the macular hole. That is, so cover the macular hole up. This is another, this is keloid. We think it's, we're going to call it keloid. So after a macular hole, you get all this undiagnosed tissue growing in the macular hole. So basically, it is not, it's all I have to say is that the ILM plug is a negative biomarker for visual acuity, okay? So these are the other things about NFAS imaging. You see preoperatively, this gives you the amount of, the upper top right image gives you the amount of ellipsoid zone loss. And post-operatively, you can still see it, it has come down. So NFAS as a tool for imaging ellipsoid zone is brilliant. This is something that we did also. It was very interesting. We measured preoperative center of the macular hole and did it post-operatively with the edges to the mesial markings, and we found out that there was commonly a shift of the center of the macular hole. So the macular hole usually shifts temporally, but some of them usually shifts nasally, but we had about 15% shifting temporally. We couldn't find a statistically visual significance to that, but it could mean something in the future. The last point I'd like to say is that ONL thickness, cystic spaces have a relationship to metamorphopsia, the metamorphopsia scale, so that could be important to talk to. So it is not only about closing macular holes nowadays, but it should be about closing macular holes and doing just the right amount of work, not to give them a worse or an equal post-operative visual acuity. Macular holes close, you're just helping them close. Okay, so that's what I'm saying. Most of us know that when you go inside, for small holes, don't do ILM peeling. You still have to just think that maybe a vitrectomy might do. And do not be afraid to tell the patient, I'll try it one more time with ILM peeling at the second go if it doesn't close with a simple vitrectomy. If you have a very small hole, please try to do it without a ILM peeling. There's nothing that says that if the ILM is there, I will peel it. Okay? Thank you very much. And again, inviting you for the Retina Imaging Congress on the July 22nd and 23rd in Toronto. Thank you.
Unni, I have a question for you. Yeah, do you leave any, we have heard about micromacular holes, probably the one which they grade as less than 250 microns now. Earlier we used to call less than 400 microns as micromacular holes. So is there any holes which you would observe and wait for a spontaneous closure, or do you even for a micromacular hole, or if it's waiting, how long, and do we go for a vitrectomy surgery in such scenarios?
Okay, when I talk about micromacular holes, I'm usually thinking of those very small 50-60 micron defects punched out in the outer layer. But anything less than that, let's say a small macular hole about 250, I always try to look at the vitreomacular status. When you look at it, you have an idea whether is there some chance of it trying to elevate, or is there no chance of it trying to elevate. You can there is, I think, a parallelism index also. When it is very parallel to the retinal surface, the chances of it detaching are less than when it has a more acute angle. So some cases I do it, but these are the cases in which I do not like to do ILM peeling. Sometimes I just let it go with just a vitrectomy and air, or just a vitrectomy and a little bit of gas, and I try to see if it closes with that.
And regarding the stuffing, suppose you have a failed macular hole surgery, and you have an open hole.
Yes.
So at that time, do you consider stuffing, or I mean, what would be your technique?
No, if I peel the ILM, and I can get some ILM, like a pedicle from somewhere, we've tried it. But interestingly, I mean, I don't know how this is, but second surgery is use of silicone oil closes a very high number. In the study meta-analysis say silicone oil for persistent or failed macular holes has a nearly 100% chance of closure, a near 100% chance of closure. So for me, rather than finding ILM, I try to find ILM. You get tons of ILM, one strip, just the edge of it goes and touches the macular hole because there's no ILM left. You've already peeled off most of it. Free flaps are never successful. I can't get them to stick inside.
Yeah, actually what we do is like under the PFCL, we peel the edge of the and drag it and put it, otherwise it will fly off. So, and with gas, maybe silicone oil is a good tamponade. Anything to add, madam?
Yeah, wonderful presentation, Uni. I agree, any kind of foreign material in the hole actually is a negative biomarker. So I have just a personal observation, sometimes if you use triamcinolone to stain the vitreous and you have few drops of it or crystals of it going down, that itself sometimes impedes the closure of macular hole. I don't know if you have also experienced that.
That's there. And also the funny thing is that I don't know when whether there's a wonderful paper that says that triamcinolone is directly toxic to the RPE, triamcinolone crystals. So having an exposure of triamcinolone, that's why all this hype about putting a bubble of PFCL inside or something inside before you use triamcinolone. Crystals of triamcinolone are toxic to the RPE is what one major study has said.
Yeah, so basically there should be nothing in the hole when you are covering it with ILM. So a little bit fluid which is sometimes present, if I have to suck it, I just suck it just before the FG because it has to be done under good visualization and then cover it with the flap and not disturb it at all.
And that's why now the temporal trapdoor flaps have come into being, just a small temporal trapdoor. But one thing about the trapdoor flaps and all this thing is that do not try to manipulate the flap till you've done an FG. That's the best way to do it. You do it after once you put it over there, you do the FG, it goes away, then it comes back, it moves here and there. So instead of touching and flipping and flopping the flap, you just leave it to the last minute and just brush it onto the...
The trick is to have your flute on the opposite side of the hinge.
Yeah.
So that takes care of it, that's all.
If you are not using a hinged flap, do you keep the ILM and do you do anything to retain it over the, since we are not stuffing, do you do anything to retain it over the macular hole after the FAE?
After FG, I just drop a little drop of Visco over it.
Yeah.
That does my job. And I don't have to stain it because after FG it is a beautifully well seen under air.
Okay. Yeah, oh, sorry.
A question. No, there is I'm sorry, the second question also?
Second question is a repeat of the previous presentation. When will you not operate the microphone?
Yeah. May I take the second question?
Please do.
No, one is chronicity. 1 year, 2-year-old macular holes and vision, poor vision. And then you have to, even if you take and very large holes, even chronic, and you see this, whether with autofluorescence, or you see a lot of RP degeneration at the thing, these are and very large holes. So, see, these would be the poor markers. If patient is bent upon surgery, then go ahead. Otherwise, leave it alone.
So there are two studies based on the size of the macular hole. One says 1,500 and one says less than 1,500. And there's another study about 750 and less than 750. In both the studies, they end with the results saying there is no change in visual acuity, but the hole closure is better in the larger macular peel. But the one study, the second study says, however, that is the interesting point, the post-operative metamorphopsia is less with a larger peel. So these are the two results of those studies. And I mean, it's very small groups, very controlled, but these are the two studies that says how it is.
I think now we have reached a point that we just use ILM to cover the hole. So if your ILM flap is enough to cover the whole size, then I think the larger peel may not make too much of a difference. Only thing that I try to focus on is that I make sure most of the edges of the hole are free of ILM. So apart from that hinge that you are keeping, the rest of the edges, so that helps relieve the traction. Other than that, arcade to arcade ILM, I don't think that works.
Thank you, Unni, for the good presentation, and we had a